see anybody outside of the normal group, but any oral communications that would like to be brought up? Seeing none, any correspondence?
The only correspondence was addressed to MAC. However, there were two individuals. There was Felicia from Kashawa, who was the other? Devin Hagee from Hunter Liggett, who
Right.
had sent an email, again, for MAC, but it applies here, in support of the changes to the EMT scope of practice.
Yep. Perfect, okay, thank you. Okay, moving on to reports. Medical advisory. I think everybody in the room was at MAP, maybe with the exception of Dave.
I'm the exception.
No, I'm an exception too.
Oh, good.
Yeah.
Leanne wants to hear it.
Maybe Liz wants to hear it.
Liz was here.
She was here.
Oh.
She's committed.
I think we're fine.
I think we're gonna hit the high points in this meeting, so
Yeah.
you'll get caught up, as well as EMCC. Moving on to old business, EPCR data project update from Jared.
I don't have a lot because I'm reporting for Laura, but the HDE project is moving along forward, moving along still. Meetings with the hospitals continue with the end goal that we could get all hospitals onto the same platform so we can get the outcome data as soon as possible. So other than that, I don't have a whole lot of specifics, unfortunately.
Question. Natividad, I know they're on HDE, but the patient information is not coming through, just the demographics. So
Correct.
is that part of this hospital meeting,
Yeah.
or is that just?
I would imagine I'm not part of that group at all, so I can't even speak to specifics,
So-
but I think the end game is that everyone would be on, you know, the same type of data flow platform, and then we would be in agreement, if you will, but, yeah.
Well, the HIE that we were trying to pursue didn't go anywhere. They were not interested to do that, and I believe Fred reported at the last meeting. So now we're moving to Plan B and see if we can do the HDE through ESO. And so we have been meeting with some of the hospitals. We have one meeting scheduled for tomorrow, and it's about addressing concerns of what is it, and get an agreement across the hospitals to say, okay, this is the data that is going to be shared, this is how it's going to be used, make sure it's protected, you know, address all of their concerns before, so that we can move forward. But we are eager to get this rolling.
But of the hospitals, Natividad has it up and running, so patient information is being given back, it's just not the
Just
health.
demographics at this
Yeah.
point. So all PCRs are now can be submitted electronically, like how they were submitting through CHOMP. It's no more faxing. So all agencies can submit them electronically. But yeah, as of right now, because there's no agreement yet, just going to see the demographics.
Okay.
Okay, makes sense.
Do we know if your reporting software will take multiple pre-hospital records? Because I don't know if that question. So if the transport provider attaches their document to your V number, if the first responder also gets that V number,
They can submit, yeah.
will it superimpose? Will it remove, or will it just add to? I don't know how your systems work.
That I'm not absolutely sure.
Okay.
Don't know IT stuff.
Because right now, there's some fire departments in our area on the Carmel side are still faxing to community hospital, where we're using a C number.
Patient contact.
Yeah, contact information number for CHOMP. So, and the first responders are like faxing, so I'm not sure if that's something, if we know I don't know the answer, so.
Well, I know that we're getting both, I think Fire and AMR are submitting electronically
Okay,
with that
so
V
you're
number.
seeing both?
We're seeing both.
Perfect.
Mhm.
Yeah, I can speak to other systems. There's sometimes a crosswalk that is created that they connect them that you can, you know, extract from the same
So-
call, but I have not.
So the next question I'd have for the first responder agencies that are responding to these incidents and, filling out, completing the ESO, EHR, a lot of initials, how can we get the hospital contact number back out to the first responder agencies, because sometimes they're not privy to, they're not readily privy to that.
So say that again?
So when we go to the hospital, they hand us a sheet. It has, Natividad has a V number on it. We add that V number to the chart, and the ESO, it automatically attaches to Natividad's record. The first responder, who may or may not respond to the hospital with us, isn't going to have ready access to that, especially imagine from AMR.
Again, not being part of this project, I can tell you how other areas have done it, is they take the demographics of the call, the time the call came in, the address, and make a reasonable, assumption that these calls are the same call, and you can pull them that way. But, having said that, I'm just saying that's how other places do it.
Yeah, this is for taking the pre-hospital report and attaching it to the hospital record. So does everyone understand what I'm saying? So basically, we have two agencies co-responding.
Mhm.
One's transporting, getting a hospital number. The other agency isn't going to readily have that available. How do we get the first responder agency that performed patient care, did an EHR on it? How do we get them that number? I'm just throwing it out. So
I don't know.
do we have it sent back?
They're on ESO.
All agencies in Monterey County are ESO.
So are they,
Okay.
do you have the means to message them within ESO?
No, we don't have any contact with the agencies. So it's just one thing to look for in terms of future
Has that been
development.
discussed before?
I don't believe, not that I'm aware of.
Okay.
So, Natividad just started using a number for charting, like last 2 months, or October, that came out. So that just happened. Community hospitals have been using their contact number for over a year now. So,
I will pass that information over to Laura. She's taken over the
Okay.
project from Fred.
maybe we can
I'm
discuss it.
third removed from this.
We'll discuss it tomorrow at QI.
Okay.
Perfect. Thank you.
Okay, any other questions for Jared? Jared, why don't you just,
Okay.
we'll skip to you.
Okay. First responder?
Yeah.
Just an update, the agency has, continued to work towards mining the first responder, response data to EMS calls by district. That project has, taken a life of its own. We're close. We're still validating to make sure we have some accurate data for every district. Once that is done internally, we'll reach out to the respective districts, share that information, and kind of go from there. The question has come up, why are we doing this? It's just more of an awareness of how the system is performing. We can use that data for, that information for many things on, ambulance deployment or whatever. So once we get there, we'll just go from there, I guess, because I don't have any other further information like when or if that information will be sent to these committees or public or anything like that. So we're just kind of taking this one step at a time.
Okay, thank you, Jared. And Steve? Implementation of new and revised policy and protocol.
The policies and protocols for the 2020 January 2nd effective date have been distributed within the 90 days prior to the implementation, so that each department, agency, organization can do the necessary training. Have not heard anything other than they like everybody seems to like the training materials that were distributed. And so the expectation is that everybody's trained, informed, and ready to go by January 2nd.
Okay, thank you. Moving on to new business, EMT scope of practice.
All right. So in response to much discussion, and also because of the opioid epidemic, we have looked at moving EMT scope of practice to be that of at least a librarian, where they can give naloxone to suspected narcotic overdoses. So with that, we find that there are additional, I believe, 10 other policies and protocols that will need adjustment simply by adding naloxone and glucometer to the EMT scope of practice. So we're going to look at those, show you what the changes are, and the plan is to put this together as an emergency policy and push it forward with a January 2nd effective date, and then concurrently we'll be running through the public comment cycle. Should there be comments related to the policy changes, and we'll bring it back to the committees in January for a final review and review of the comments. So with that, any questions before I begin regarding the process? All right, so looking specifically at the policies, we have the scope of practice policy for EMT, and going down to the red. So simply by adding language that pretty much mirrors what's in Title 22 for the EMT scope of practice, it's under basic scope, but there's a section under the basic scope that allows for naloxone, epinephrine, glucometer, and aspirin if the medical director says yes and provides policies for that. So we put aspirin in quite a while back because if dispatchers can suggest that you take an aspirin, or EMT should probably be giving aspirin. So we've done that a while back. So these additional skills that we have, and the language is written because it requires the individual to work in the system. You can't have just an EMT going out and giving naloxone under our policy. You have to be functioning within the system. So it allows for naloxone and blood glucose testing. It also allows for naloxone by IM route, so direct injection, and we'll talk about that when we get to the policy. So because we add this to the basic EMT scope of practice, our EMT expanded scope of practice no longer needs naloxone and glucometer in there, so simply have been removed. Next policy is the expanded scope accreditation, because this talks about the training required and mentions specifically those two items. They're being removed from that policy. Next we have authorized stock, and we've made an adjustment or we will be making an adjustment based on MAC comments that there should be 2 of the naloxone on the BLS side, because the policy says he can repeat, so we should be able to repeat the dose. So we'll update that to 2 intranasal naloxone. All right, next is protocol overdose and poisoning. So we've added suspected narcotic overdose under substance-specific treatment, and there's naloxone 4 milligrams, and this is basically if the parameters if the respirations are less than 10 a minute. The policy is also going to be updated on the paramedic side. The second, if you go to the second page. So what we have here is a lesser dose for the paramedic providers. So we'll be still giving 2 milligrams, but the maximum dose, instead of a repeat one time, will go to up to 8 milligrams as needed for respiratory depression.
And aren't they also reminding the titrate because the way the dosage is given? So she reworded that.
Yes, that's on the pediatric one.
Yeah, okay.
Now, while we're in here, we do have and go up to the BLS side. So what we do have here is just the intranasal administration. What we're thinking about, and MAC approved, so we'll write this in, is for the EMTs on paramedic units, ambulance or fire engine, that they can give intramuscular IM injection, so that if they don't need to carry both the intranasal as well as the injectable naloxone. So MAC members like that idea. Any comments here. But apparently, the ambulance at least is carrying both already, both injectable as well as inhaled, or intranasal. Okay.
I just have a question. Is it, we're just gonna be doing repetitive IM injections? I mean, we've got it. So should that say the first one and then may repeat, or, because that's,
So to do IM injection on the BLS side, I'll need to add language into this that's specific to the IM.
Okay.
So it'll be naloxone up to 4 intranasal, and then if ALS, working on an ALS unit, you can give intramuscular, and we'll set the parameters looking on the paramedic side.
and then go down again, please? Why should we put a limit on administering Narcan in terms of policy? I mean, especially for the more remote rural areas where we might be chasing ourselves and don't have communication, then we're just going through another step when there's no contraindication.
That's what we discussed. I'll let Dr. Billy weigh in.
Yeah, I think we kind of discussed multi-dosing on Narcan up to a certain limit, which we had discussed as 8 milligrams, which is a pretty hefty dose.
Sure.
Granted. There may be cases in which you need to redose and go beyond 8 milligrams, but I guess it could be argued whether we're seeing that more, and maybe we'll be seeing more cases in which we do need to go beyond that. If that's necessary, then we felt that it would be prudent to just contact medical control, if possible, to touch base with them and let them know that you have a severe narcotic overdose and you're now beyond your 8 milligrams and still needing to redose.
Yeah, and I just, especially for something that's not super sensitive and, contraindications, and for what it's being used for, and also for all the fentanyl stuff, everyone's having to really go deep. I mean, Chomp's not here. They had one, I think they gave 8 milligrams or something like that. But for our remote areas and stuff, and my concern is not up to 8, it's just how it's worded so that we can just keep moving forward and not have to stop in the middle to mother may I, for continuation, especially if we're, going down that path. So that's all my concern is.
Thanks. All right, next policy is non-traumatic neuro CVA policy. It has blood glucose measurement, simple add. We didn't have it specifically in the paramedic side, so if we do it, we'll add it. Next. Seizure, same thing. Suspected hypoglycemia, again, just add the language, allows EMTs in these situations to do a blood glucose measurement, and if it's there, no need to be in the ALS side. The pediatric overdose and poisoning, in addition to what's here, we have some suggestions from MAC for changing. So instead of titrate for the naloxone for improved respiratory function, it's redose for persistent respiratory depression or similar language. Because if you're giving the intranasal, it's very hard to titrate that administration stuff. And then if you go down to the, no, not quite that far, paramedic, the ALS side for narcotic overdose, will also be increasing up to 8 milligrams because BLS can do that. And then also because we're not titrating anymore, but we would for intravenous and IM, then we would move the intranasal to a separate line item and how to give it that way. So those suggestions came out of MAC. they'll be making those into the draft policy. Okay? You'll have pediatric seizures, blood glucose check, just taking language from the paramedic side, moving it to the BLS side.
God bless America.
Bless you.
And then for the suspected hypoglycemia for pediatric, same thing, just move the blood glucose check up to the next one. And those are the policies that need to be changed and protocols that need to be changed when we move through the BLS scope of practice to include naloxone and glucometer. With that, we also have discussion this morning and have the discussion here related to epinephrine auto-injector. And historically, the big reason that it's looked at where we don't necessarily want to always move there quickly has to do with cost. And apparently AMR has found that they can get the epinephrine auto-injectors, the duodones for adult peds dose within the same device for less than $50 a piece. So there's interest from MAC to explore this further, so we'll be exploring that and bringing it back to the committee for policy changes and scope of practice changes for epinephrine auto-injector for anaphylaxis. With that, any questions or comments?
Great, thank you very much, Steve. So, gonna be a short meeting, which is fine. Moving on to announcements. Teresa, did you want to talk about EMS agency staffing?
Sure. Most of you have already heard the announcements, but some of you have not. So we have some updates on our EMS agency staffing. First, the good news is that we have hired a new EMS analyst. This is a position that became vacant earlier this year. And so we have Thomas Woodland, who joined us just yesterday. And if you would like to just tell us a little bit about you.
Third time's the charm.
Really good. As folks say, did you want to hear this again? No. I'm Tom Woodland. I come from recently IFT field supervisor role in Santa Clara County for 2 years. Before that, I was in Tulare County, specifically Porterville, for 10.5 years in the 911 system. Just here and glad to be here and humbled and looking to serve everybody's needs and have a great partnership with everybody.
The other update is that Fred Claridge is no longer with the EMS agency, but he's still with the county. He moved on to the Office of Emergency Services. We should be recruiting for his position. And the last one is the EMS Director position, as everybody knows. I think everybody knows that Mike announced his retirement effective November 15th. So the day after tomorrow is his official last day with the county. There will be a recruitment for that. I don't have details at this point, but for the time being, I'm acting in interim EMS Director. That's all I have.
Okay, thank you, Teresa. Any questions regarding EMS staff? Okay, let's go around and finish up with the roundtable. And I'd just like to say, number one, it was a pleasure to meet Dr. Burley. Great to have you here. And I also want to acknowledge the return of a spirit of goodwill and collaboration, which I think is the environment in which we are all most productive and most able to do the jobs that we're here to do. So thank you very much. It's the feeling of normalcy is coming back. Just wanted to acknowledge that. That's all I have to say. What's that? Normalcy is a fallacy. There's no such thing. Deviation of normalcy. Right. Any other comments?
I just wanted to bring up what I spoke with Scott, and I know Jared is very well versed in this topic. So last week we experienced operational change throughout the county that caught several agencies off guard with the lift assist protocol, and that whether I missed the memo or something like that, I guess I wasn't the only one, because I know it came from many different agencies as well. So I just wanted to ask that if there's a way If something's going to come down, that we can pass this information along and give us as much advance warning as possible. Because there was fire departments scratching their heads, why is an ambulance coming? People were questioning whether it was a medical, should they go code 3? I mean, lots of different things came down. And I know Jared had been working hard over the last 18 months to implement and with the county and get this stuff going, but somehow something fell through the gap. And, you know, just for, and I feel EMS ops, that would have clearly come well into this body in terms of passing through the information. I know, as you pointed out in several of your emails, this is between the county contractor and the EMS, you know, LIMSA, and I get that, but it obviously had a broad effect, so. My 2 cents.
Yeah, I mean, I agree. We can work on communication, tweaks, unusual occurrences, questions, reach out. I'm happy to clarify. You know, I don't know of the specific move forward with this, but, you know, as we mentioned in other meetings, that the 3000 series will be talked about next week. So we'll try to really ensure that any and all, you know, changes get communicated effectively out to the group, so that you can go out to your group and explain it effectively as well. But if any question, you know, pick up the phone and
Sure.
ask, you know, I can clarify, or maybe we missed something or whatever.
Well, it was almost like it was a Friday afternoon that it got brought to my attention. By that time, it was already into the weekend before, you know, you felt the full effect of what's really going on. So had to wait till Monday.
Well, we do have the duty officer, I mean.
Oh, I don't think it reached that level, but yeah.
Yeah, but Monday, 8:02.
Yeah, I think so. Yes. First response.
So I just wanted to bring that up again about the 3,000, but you already brought it up, Jared. It was brought up in the earlier meeting about the groups being part of it again, or feeling part of it. And Jared did say, you know, it's education, and we'll be talking a lot more collaboration. So I'm hopeful because the meetings feel different, so thank you.
And now I'll just respond to Eric's comment, and again, I'm kind of coming into the system fresh and having an opportunity to meet everyone, and so far I really appreciate how everyone's you know, approached me and you know, come with a spirit of collaboration and communication, which I think is key to making a complex system like this work with multiple players and a complex set of protocols and geography and patient population. So there's so many moving parts in a system like this, and it only works with good communication. And so I think this is great to have these meetings, but also feel free to, you know, just shoot us emails, pick up the phone and call us. We'd rather, you know, have these conversations as issues come up, and be able to maybe you know, head some things off of the past that may be just a communication gap or something. So in that spirit, hopefully we can continue to move forward and get a lot of good work done.
Good, thank you. Any other comments?
Eric, at the last meeting I had requested that we agendize EMS air operations for review and discussion. Again, to reiterate, there's been multiple anecdotal reports of concerns regarding the air utilization of an air provider out of Fort Hunter Leggett and discrepancies in ETAs. So I just want to ensure that all air ambulance providers permitted to run 911 calls within the county are being held to the same standard and are under a similar review.
Okay. You're asking for that to be?
Yeah, I think last time we had briefly touched on it with Firecom. Firecom is going to look into, you know, if there's any way that we can, you know, get insight as to the reliability of ETAs and response times from our ambulance providers in the county. We're doing this in neighboring counties, and it's been quite insightful, working pretty closely with other LIMSAs to ensure that we're providing the most accurate ETAs to ground first responders, so that appropriate transport decisions can be made.
Okay.
Did Jen reach out to you?
No, ma'am.
I followed up and asked her to reach out to you to answer some of your specific Firecom questions. But as far as reaching out to the agencies and their expectations of ETAs, I didn't really think that would fall under 911 to set those expectations for agencies' response time. Not something we normally get involved in.
Yeah, I agree at the agency level. I don't think there's much of an issue. It would be more, it sounds like you're looking for more of a broader,
Yeah, I mean, if the agency is gonna maintain.
Snapshot.
Any oversight of that, as far as ensuring accuracy and regulating, I think that may be appropriate to lie with the agency, as the policy 4070 is, an agency policy. And there is pertinent language in the policy that comes into play, whereas it references utilizing the closest air ambulance, but the closest air ambulance, if they, for example, have a 25-minute lift time to respond, may not necessarily be the most appropriate air ambulance to respond.
this is mostly a South County or coastal.
Yes. Yeah.
Okay. Sounds like maybe the best way to do this is we'll get together quickly after the meeting and make sure that your concerns are addressed.
Sure, thank you.
Okay. All right, unless there's any other comments, thank you for your attendance. We are adjourned, and Teresa, correct me if I'm wrong, January 8th.
January is the next
Okay.
meeting.
All right, thanks,
We-
everybody.
In case, normally we meet here, but we have to book the meetings, the rooms way ahead of time, so we're hoping not to lose this room. But
Okay.
if so, then we'll update everybody on the location.
Okay, very good.
Is it gonna be in this building today?
Yes,
Okay.
yes. We like this room, but, it's a very popular room.
Sure. All right, thanks, everybody.
There's that.